First to introduce the Dr. PC Manoria sir, who is going to take the session of the Dapa Hf in the management of cardiorenal continuum in heart failure. So, as Dr. PC Manoria sir, he is the currently director of Manoria Hospital, Bhopal, and former professor of the and HOD of Gandhi Medical College, Bhopal, and also being the past president of API during the year of 1998 to 1999, and being the past president of CSI from the 2004 to 2005. Not only this, Dr. PC Manoria sir already being the chairperson of the Hypertension Council of Asian Pacific Society of the Cardiology during the tenure of 2004 to 2013, and being the vice president of the SARC Society from the 2006 to 2007. So, without further delay, I would like to welcome Dr. PC Manoria sir for the delivering their session. Dr. Manoria sir, over to you.
Yes, just a second. Good evening, everybody. I'm sure all of us enjoyed the flashes of expertise during the brilliant discourse of Dr. Tiny Nair. I'll be talking to you on dapagliflozin in the management of cardiorenal continuum in heart failure. The first big message in this context is that the combo of heart failure and CKD is a deadly duo and is associated with very high morbidity and mortality. But the good news is that SGLT2 inhibitors are powered to slow down the trajectory of chronic kidney disease, and they delay the declining eGFR and roughly provide 10 to 11 year postponement of dialysis or renal transplant. And as you have already heard, SGLT2 inhibitors also improve the outcome of patients of heart failure HFrEF. The second big message, which already pointed out by Dr. Nair, is that heart failure and CKD remain asymptomatic for a long time. There's a lot of potential to improve the outcomes. Heart failure, we know treatment should start in stage A and B, and we have now very good drugs like SGLT2 inhibitors, DAPA and others. And in CKD also, it has been shown in the DECLARE TB trial, when eGFR was just below normal, 85 mean, there was a tremendous improvement in the renal outcome. So the big message which should go to all the practitioners and physicians: diagnose and treat asymptomatic CKD, asymptomatic heart failure. You can immensely improve the outcome of these deadly duo by various agents. Now, it is not uncommon to see patients of diabetes with heart failure, kidney failure, and FLD. And this occurs because there is a very intimate cross-connect between diabetes, heart, kidney, and liver. What is this interconnect? Diabetes commonly results in heart failure. Patients with heart failure are at increased risk of diabetes. 1/3 or even up to 2/3 patients of heart failure have CKD at the time of diagnosis. And what is very interesting is worsening of heart failure worsens CKD, and worsening of kidney failure worsens heart failure. And the third cross connect is between diabetes and liver. Diabetes, all of us know, produces NFLD and even NASH, and NFLD produces diabetes. And therefore, when you're treating patients of diabetes, you must remember this cardiorenal metabolic continuum. And interestingly, SGLT2 inhibitor is powered to target both these serious comorbidities, that is heart failure and CKD, and greatly improves the outcome of these comorbidities. And after the Dapa Hf trial, after the Dapa CKD, Dapa has slashed the boundary between diabetics and non-diabetic patients. So DAPA can now be used ubiquitously in patients of heart failure and kidney failure, whether they are diabetic or non-diabetic. This other big message in the context of cardiorenal outcome is all of us must never forget every hospitalization, every rehospitalization takes the patient closer to death. So if you are able to prevent hospitalization and rehospitalization, this is indeed a great achievement. And as you have already heard from Dr. Tiny Nair, DAPA and other SGLT2 inhibitors are powered to do this great job. In the context of kidney diseases, never forget every acute kidney injury with every acute AKI, although the patient may recover, it is always associated with permanent loss of some glucose and slowly takes the patient closer to ESRD if the patient is suffering from recurrent AKI. So admission to hospital for heart failure or AKI, both should be taken very seriously. We should attempt to prevent, and indeed they can be prevented under several circumstances. So prevent hospitalization for HF, prevent acute kidney injury are the key message for the cardiorenal continuum. Now, when we look at the morbidity and mortality in CKD, as you can see, as the CKD rises, hospitalization increases, cardiovascular death increases, death from any cause increases. So CKD runs hand in hand with heart failure. And this is so important because CKD impacts 1 in 10 people globally. So the burden of CKD is huge. And when we look at the improvement in the CKD mortality, prior to SGLT2, this was limited while renal replacement therapy continued to rise. Now, after the SGLT2 inhibitors, we are very sure that the outcome of CKD will improve with these new agents. And in past, the vast majority of large-scale trials in CKD were done in diabetics, but Dapa Hf and Dapa Ckd had taken very bold steps. They have tried this patient in non-diabetics, and both trials have been positive. The peculiar feature of all CKD trials, whether it is CREDENCE or Dapa, both trials have been prematurely terminated, and therefore the benefit is immense. And when we look at the therapeutic innovations to prevent new onset or worsening renal function, after the ACE-ARB era in early 2000, there has been no major advancement. Trials of ACE-ARB combo, DRI, sulodexide, and all have been negative. But DAPA has the SGLT2 inhibitors, and DAPA CKD has provided the second revolutionary step in CKD management. So if you have both these diseases in a combo, you will have more symptoms, quality of life will worsen, more hospitalizations, and more mortality for obvious reasons. You've already listened to heart failure. Heart failure, the statistics are horrifying globally as well as in the Indian context. And once heart failure sets in, it runs a malignant progression with a very high morbidity and mortality. In diabetic heart failure, the mortality is 85% at the end of 5 years. And pharmacotherapy or device therapy only blunts this malignant progression. It does not arrest it. So prevention of heart failure is of crucial importance. And indeed, this can be executed easily, as you have already heard from Dr. Tiny Nair, right from the stage A. We use SGLT2 inhibitors and other drugs, even if the patient is symptomatic. HFrEF, FPM, not going to go into detail. Now, this is also very interesting. The first 3 initial cardiovascular outcome trials, EMPA, REG, CANVAS, DECLARE, in fact, laid the foundation stone for exploring the renal benefits. When these trials were conducted, they were mainly conducted for CV outcomes, but look at this consistent renal benefit with all the 3 trials, EMPA, CANVAS, and DECLARE, nearly 50% or 45 to 50%. And what is very, very exciting is that the eGFR in the DECLARE trial, as you can see, mean was 85.2, just near the normal, and that produced also a great benefit, as you can see. The albuminuria improved. That slide somehow will show you. And When Dapa HF was undertaken, the kidney outcomes were also assessed. And this also has been talked by Dr. Tiny Nair, that the mortality benefit is more with the Dapa HF compared to the Emperor, although other benefits are same. Why there was no reduction in mortality with Emperor compared to Dapa? Several hypotheses has been made, as you can see on the screen. And this also that the patients were more severe, anti-proNP levels were higher, and so many others. Ejection fraction was lower, but I think the exact mechanism is yet not known. And this again has been shown whether eGFR is less than 60 or more than 60, the benefits are there. And now this is also important. When we look at the issue of acute kidney injury, you can see Dapa 44% reduction in educated acute kidney injury, which is again very, very exciting. And all these trials and data from the CV outcomes laid the foundation for Dapa CKD trial. And the beauty of Dapa CKD trial is again, the trial was prematurely terminated because of immense benefit. It's a large mortality morbidity trial for CKD. And in fact, Dapa CKD laid the first foundation milestone for utility of SGLT2 inhibitor Dapa in non-diabetic patients. The CREDENCE was dedicated to diabetic patients. So Dapa CKD has initiated a new revolution in the management of CKD. The benefit of SGLT2 inhibitors were passed on to non-diabetic patients. And this is indeed a great achievement. There was a dramatic reduction in CKD progression, as we'll see, and provides a new opportunity to improve outcomes in CKD. All of us as cardiologists should be familiar with the CKD classification, but those who are not familiar, we classify CKD into 5 grades depending on the decline in GFR and the proteinuria. The more is the proteinuria, more adverse is the prognosis. The lower is GFR, more adverse is the prognosis. So when we look at the trajectory of chronic kidney disease, what do we have? The normal decline in GFR on an average is 0.9 ml per year. Now, before RAS blockers came into scenario, we had no other agents. So diabetic CKD, the fall in eGFR was 10 ml per year, and many patients of diabetic CKD prior to the RAS era were submitted for dialysis and transplant, and the outcome was very well. RAS evolution, RAS blockers had the first revolution in kidney disease, and they improved the decline in eGFR from 10 to 4.5 with 9, almost 50% or slightly greater. And on top of RAS blocker, the second revolution which came is with the SGLT2 inhibitor, and they further decreased the slowing eGFR by 58%. So from 4.59, it dropped to 1.85, and this is indeed a great achievement. And so SGLT2 inhibitors have provided a new opportunity to improve renal outcomes in CKD diabetics as well as non-diabetics. And we have now the third revolution coming up, the trial with non-steroidal MRAs. The Fidelio trial has shown positive results. The whole trial is going to be presented very shortly. So although we do not have a quick fix like angioplasty, primary angioplasty for CKD, we have 3 magic bullets which can improve the outcome. So even if your GFR is low to begin with, all these agents can bring your DR to a closer level compared to the normal, and your lifespan can be prolonged to a great extent. What is also emerging from this is, whenever we try any new agent, we use it on top of it, so patient requires to use multiple drugs. A new thought is emerging is, why not use SGLT2 inhibitor first and then RAS blockers in the reverse direction? And many people believe that the benefit of SGLT2 may be greater than the RAS blockers. But I don't know whether such a trial will be conducting, but the thought is quite good that SGLT2 inhibitor may become the first agent and then the RAS blockers, looking at the benefits of SGL, not only in kidney disease, but also in other aspects. So now if you have a patient, what does SGLT2 do? If you're on a RAS blocker, your eGFR is 4.59 average. When you use SGLT2, it becomes 1.85, and you can see you get 15.1 year postponement of dialysis and renal transplant. So it's indeed a very great achievement, and SGLT2 inhibitors should be started early in the course of CKD, even when it is asymptomatic. And this is the Dapa CKD trial. You have heard already on some webinars. Dapa 10 milligram was compared with standard of care, and the inclusion criteria are usual: more than 18 years, eGFR, unlike the CREDENCE trial, was 30 and onward, has 25 to 75, so still more severe CKD, and UACR 200 to 5,000, and stable maximally tolerated ACE-ARB. That was mandatory because they are the first agent at the present time, and non-diabetic or diabetic. And we'll see the primary and the secondary endpoint. This shows the baseline characteristics. You can see there are diabetic patients and non-diabetic patients. And this is again very exciting. Look at the eGFR, more than 60. You have already heard 45 to 59, 30 to 44. Less than 30 GFR, 14.5% out of 4,000 patients. And look at the albuminuria UACR, 30 to 300, 10.3% of patients, which would roughly amount to 400 patients. All these patients also benefit, giving a new message. Then even if your GFR is low and proteinuria is not markedly increased, SGLT2 inhibitor DAPA has shown benefit results. And this shows the participating countries. India has about 200 patients. And this is the primary composite endpoint. Look at this. There is a 39% relative risk reduction. Look at the NNT 19. And this is in terms of sustained greater than 50% decline in eGFR, EK, CD, SD, renal, and CV death. Here you can see the curves are separating after 8 months. In the DECLARE trial, they separated after 2 years, clearly giving a message that if you have a mild CKD, curves takes longer to separate, but if you have severe CKD, the benefit comes early, and that's what we desire. And look at this. All hazard ratio of the individual components of the primary are leftward. All the confidence intervals also leftward, except the cardiovascular death, which is 1.12. So the benefit is seen universally in all the endpoints. And look at the subgroup analysis, whether you have diabetes or no diabetes, the benefit is there. Albuminuria more than 1,000 or less than, eGFR less than 45, more than 45. And look at this age, whatever is the age, gender, race, geographic distribution, systolic blood pressure. And this is the benefit in the secondary endpoint, which means dedicated kidney outcomes, excluding the cardiovascular death. So chronic dialysis, kidney transplantation, renal death, again, you can see a significant reduction of 34%. And this is the secondary endpoint in cardiovascular death or hospitalization for HF, 29%. And this is all-cause mortality. Dr. Tiny was talking. This is also seen in the CKD, a 31% reduction. And look at the P. So very statistically significant reduction in all-cause mortality. It's DAPA CKD. How does it act? The mechanisms are complex, but it is believed that tubulo-glomerular feedback plays an important role because SGLT2 blocks the proximal glucose and sodium reabsorption. So there's increased delivery to the macula densa. The TGFs gets activated, the afferent arterioles gets constricted, and you get a reduction in intraglobal pressure and the proteinuria. Great safety, no issues. All the agent side effects are negligible. So in summary, we have DAPA CKD, 39% reduction in the primary composite, 44% in the dedicated renal composite endpoint, 29% reduction in CV death and hospitalization for 39% reduction in all-cause mortality. All figures are statistically significant. And as we have already told, the benefit was across the board, diabetic or non-diabetic, very good safety profile, and therefore Dapa CKD has built up the evidence of Dapa on top of the two pre-existing DECLARE and the Dapa HF trial. Now, this is again very interesting. If you look at the eGFR, DECLARE, we talked of 85%, 85 GFR, and look at the benefit in the renal outcome, you can see a 47% reduction. So even if you have a mild decline in GFR in the range of 85, which is the mean, you are asymptomatic, Dapa will benefit. If the GFR further declines, 66 mean eGFR in the Dapa HF, again you get a benefit which is 39%, 29%. And if you are in a Dapa CKD, again you get a benefit which is 39%. And all these trials obviously produce a reduction in the hospitalization for heart failure, and Dapa HF initially produces a reduction in the cardiovascular death in all-cause mortality, and so also the Dapa CKD. So Dapa has shown positive results across the continuum of cardiorenal protection in people with and without type 2 diabetes. When the DECLARE trial was presented, people said no mortality in DECLARE, no mortality with DECLARE, but Dapa HF and CKD has shown decrease in cardiovascular mortality and all-cause mortality. So we have a population of primary and secondary prevention in DECLARE with dapagliflozin. We have Dapa HF trial, HFrEF, diabetic and non-diabetic, and we have Dapa CKD, diabetic and non-diabetic. So Dapa has nearly completed the whole circle. So now when we look at the achievements of the three front runners of SGLT2 inhibitors, the EMPA, the CANA, and the Dapa, although these trials cannot be compared, the populations are different, but let's see what we have achieved. The decrease in hospitalization for heart failure and renal protection is indeed a class effect. All SGLT2 inhibitors decrease hospitalization, all improve renal outcome. The outcome of renal outcome is better improved compared to the hospitalization. Now, when we look at the canvas, what we have the CREDENCE trial of primary and secondary infection and the dedicated diabetic subset trial of CREDENCE in the CKD. EMPERAGE, we have the EMPERAGE outcome, secondary prevention trial, and EMPEROR again, a secondary prevention trial. And EMPEROR has shown same decrease in hospitalization for heart failure, but CV mortality and all-cause mortality are not comparable to Dapa. Dapa has primary and secondary prevention data. Dapa has diabetic and non-diabetic heart failure, HFrEF, and Dapa has data for CKD, diabetic and non-diabetic. In addition, a decrease in cardiovascular mortality and all-cause mortality. So although the trials are not comparable, Dapa has little edge. But more important than that is, instead of comparing these agents, we will spread the benefits of SGLT2 inhibitors, and medical preventary is not self-sufficient to spread the messages across the physicians, practitioners, and the general population. So we should use all media to spread the benefits of SGLT2. They are great molecules. They improve cardiorenal outcome. They are life-saving drugs. The safety is great. They are practice-changing drugs. The guidelines have changed. Previously, diabetic guidelines never used to have a place for the CV outcome, but they now heading the all guidelines. They are guideline changing and they are cost-saving. You treat heart failure in early stage, CKD in earlier stage. I think this will save a lot of cost in the long run. And SGLT2 inhibitors are great agents, and many patients say you have really changed the life of them, all these patients. So thank you very much for your kind attention.
Yeah, thank you so much, Dr. PC Manoria. Such a lucrative presentation you had delivered. As always, you have made the presentation so live, and you cover the all holistic approach where from the DECLARE journey we started the benefit for the two main organs like the heart as well as kidney, which already been proven for the Dapa HF and Dapa CKD trial, not for the benefit for the diabetic, even for non-diabetic patient population as well. So moving further, we have the few questions are in our chat box. So just wanted to take on that. So first question for Dr. Tiny sir. Since Dapa has labeled at present for HFrEF, you suggest to use dapagliflozin or any SGLT2 inhibitor for the same?
Can you repeat that question?
Since dapagliflozin has a label at present for the HFrEF treatment, you suggest the use of dapagliflozin
Yes.
or the any other SGLT2 inhibitor for the HFrEF patient, irrespective of the diabetic and non-diabetic condition of the patient.
Yeah, initially to start with, we had the Dapa Hf, which showed very clearly that we get enormous benefit in heart failure by using dapagliflozin, right? And after the Emperor reduced came in, we saw movement in the same lines, right? These are not head-to-head trials, but we should look at the trend of benefit, and we did find that empagliflozin also produced reduction of heart failure outcomes, both in diabetic and non-diabetic. So this was not the first results were never flawed. It was supported by a second large trial. And what do we learn? That yes, we get reduction of heart failure, hospitalization, and cardiovascular death on using two SGLT inhibitors, one in dapagliflozin or empagliflozin. Now the point here is, remember that Vertis CV. Vertis CV has shown that, like Professor Manoria has shown, there is benefit in reduction of heart failure outcomes, but there is no benefit in MACE. So, every drug is individually different, and you should use the data that is available only to practice evidence-based medicine. Why I'm talking about this is, we see today in India, in the Indian market, you have a lot of gliflozins which are not approved, right? See, the point is, when you are using a gliflozin, SGLT inhibitor, you are not using it to reduce the sugar number, right? Then you could have used anything, right? Anything. Why we use an SGLT inhibitor is to reduce some end event. They are cardiac, and as you have heard Professor Manoria, renal. So if you want to reduce the end event, you can only use drugs that have been very clearly shown in large RCTs to do that. And today we have proved that that is done by only two SGLT inhibitors, dapagliflozin and empagliflozin, period.
Yeah, thank you so much, sir. Sir, the another question for Dr. PC Manoria, sir. Sir, at what level of eGFR we can use the SGLT2 inhibitor in the CKD, as well as is the renal benefit is a class effect?
The levels up to which eGFR SGLT2 inhibitors is now 25 after the Dapa CKD trial. In the EMPA CKD, it is up to 20. With the CREDENCE, it was 30. So because Dapa CKD has shown positive results, you can easily use up to 25. And I've shown the subset of patients whose eGFR was less than 30. Even the CREDENCE trial subgroup analysis is going to be published very soon, which showed great benefits in the subset which had eGFR less than 30. But documented wise, we can use up to 25, and after EMPA CKD is released, it may slash down. What is very important to remember is, for glycemic control, the cutoff point is 45, but this is not the cutoff point for CKD benefit. It seems that as the glycemic benefit decreases, the CKD benefit improves. Because when we saw the declared TIMI 58 trial, the curve starts separating after 2 years. But with Dapa CKD, you see curve starts separating after 8 months. So it seems that CKD benefit starts coming up when glycemic benefit decreases. So that is very peculiar of feature. So that is the present state of affairs.
Thank you so much. The same sort of question by Dr. Pankaj side. Can DAPA be used in the patient with ESRD or on the dialysis with the CHF patient, or do you recommend it, the use of DAPA in the ADHF patients?
See, the data on dialysis patient is not available. The cutoff point for Dapa CKD was 25, and they have not been tested in ADHF as yet. So we don't know after ADHF hemodynamic stability, as we did with the ARNI trials, may be there to use it. But ADHF is not an indication. After hemodynamic stability, if a trial comes, it may become an indication.
Absolutely, I fully agree with Professor Manoria. See, right now in these areas, there are no data available. There is, but if you actually look into the way the things are developing, like Professor Manoria said, the benefit is GFR independent, right? Whatever level of GFR you use these drugs, you are benefiting. They're not dependent on glycemia. They're not dependent on systolic blood pressure. They are independently renoprotective. They're independently cardioprotective. So it looks like that number we have taken in Dapa CKD 25 and EMPA CKD we have taken 20. That is different. And CREDENCE it was 30. But whatever we had taken for a trial purpose is not important. But then if you look at it, there's independent of GFR, there is benefit. So that is what we should take up. So I believe that in course of time, we will find that, like we today talk about ACE inhibitors, as long as you can manage potassium, and as long as you know that even your dialysis worst patient with a GFR of 10, an ACE inhibition might benefit in slowing down his worsening of renal function. So I suppose looks like it is going to come to that, whereby patients of any GFR, on dialysis or no dialysis, we might clearly see a benefit. And see, all of us as cardiologists have cases where we had seen that the patient was extremely bad, not responding to anything, and finally, as a last resort, in the ICU, ADHF, we have given a small dose of dapagliflozin, and we have quite a few cases who have improved, right? Is there in guideline? Absolutely no now. But all of us believe that a day is going to come when in acute decompensated heart failure, we would be probably using these SGLT inhibitors.
Yeah, thank you so much, sir. As you rightly mentioned that the use of the EGFR, which condition we need to use. Another next question by Dr. Asha Murthy side. So just need to addressing by the Dr. Tiny has said the SGLT2 inhibitor have anti-arrhythmic effect and anti-inflammatory effect as well. Does it have any adverse effect for
Any adverse effect for?
on the same part for the arrhythmic effect and the inflammatory effect? Both are there. So any side effect which may be being parallel?
No, see, the point is we should understand that SGLT inhibitors are the only group of drugs where we have gone from bedside to bench, right? Normally, all drugs are developed in an animal model. Then we go on to phase 1, 2, 3, 4 trials. And then for that indication, it comes to clinical medicine. But that is why we say bench to bedside, right? Lab to clinical medicine. But this is the only group of medicine, the SGLT inhibitors. We have gone back from bedside to bench. So we introduce this for glucose excretion in urine. Then sodium comes out, so good for hypertension, diabetes. Then now we see that they're benefiting heart failure, they're kidney protective, they're myocardial protective. So we have gone from bedside to the bench, talking about sodium hydrogen exchange inhibition. We have talked about ketosis, we have talked about hundreds of things. But very truly, even now we are not very sure how the benefit comes in. Now we should understand that any drug that improves cardiac function, whether you are talking about ACE inhibition, whether you are talking about beta blockade, whether you are talking about mineralocorticoid antagonists or ARNI, they tend to reduce major cardiac arrhythmias simply because you reduce the end-diastolic volume, you reduce the stretch on the myocyte. So the focus of arrhythmias that develops is less. In fact, we have data on ARNI telling that very clearly with ARNI, the number of shocks needed by a device comes down. So obviously, there is an anti-arrhythmic benefit. But is it beyond the point of improving LV function? That we know? Do we have a very clear evidence of anti-arrhythmic effect by SGLT inhibitors? We don't know. But there is some data from Toronto, Dr. Shod Verma's lab, where animal studies have shown that myocytes incubated and being tested shows less of arrhythmic propensity when given in a condition of a lab under influence of dapagliflozin. But that does not come in clinical medicine. Anti-inflammatory effect, possibly yes. It might be one of those reasons why we get reduction of MACE, reduction of plaque rupture. But these are all conjectures. We are not sure about them.
It is
Thank you so much,
true
sir.
that
Dr. Manoria, sir,
yes, it is true that there's no any large trial, but why this arrhythmia business is coming into picture, because all SGLT2 inhibitors have shown decreased sympathetic activity. You decrease blood pressure, your heart rate does not. In some of smaller data, it shows decrease in heart rate up to 10 to 15, clearly indicating that it has an anti-sympathetic activity, which may be explored in future.
Yes.
A small trial was published, some few patients, which showed decrease in the urinary norepinephrine levels also. So this is to be explored. At the present, we do not have any hard data. Regarding the anti-inflammatory effect, I think the AstraZeneca will be better person. They have started trial in COVID. They are 19, thinking that it has anti-inflammatory action, although the drug is not to be used in the ICU as per the standard recommendation. But one of the beliefs is that it's an anti-inflammatory action. So again, this has to be explored, but they were very bold, and the trial itself is a day 19 trial. So that maybe they are worth exploring. Anti-inflammation act all can also benefit coronary artery disease and atherosclerotic coronary artery disease, and that we know. So that is to be explored.
Thank you so much, sir. Sir, another question for Dr. PC Manoria, sir. As the dapagliflozin are able to show the benefit for the renal as well as heart, so which benefit is more? The renal benefit is more or the heart benefit is more? What is your key on that?
The renal benefit is obviously more, it's overwhelming the heart benefits. Although it was tried even in DAPA, all trials have shown the renal benefit is up to 40 to 50%. The cardiac benefit is up to 25 to 30% or maybe 35%. So obviously renal benefit is more than the cardiac benefit, no doubt about it. And it's universally shown. In fact, decreased hospitalization for heart failure and renal benefit is a signature of SGLT2 inhibitors. Wherever you will put SGLT2, it will produce renal benefit, it will produce heart failure benefit. It's a signature effect.
Thank you so much, sir. Another question for the same for Dr. PC Manoria, sir. What do you think are the future prospects with the dapagliflozin in the HFpEF patient profile?
I think at the moment we do not have any trial. The DELIVER trial and the AMPA preserve is ongoing. But the speculation is that it may be useful and there are some reasons to believe it. But the final results will be after these trials are. The first reason is that some patients in the declared TIMI have HFpEF, and the trial showed improvement in this subset of patient also. The second reason is that all drugs which have failed in HFpEF mediate through the neurohormonal blockade. This is a drug which acts through newer pathways. Some of the pathways we even do not know, may be one of the reasons to believe, because this pathway has not been tested. The third reason is that it produces decrease in the interstitial edema in the myocardial. So it is believed that if the edema is decreased, even if the myocardial fibers are not altered in terms of hypertrophy of fiber, they will be able to relax better and the diastolic function may improve. So these are a few reasons why some of the people speculate that the trial may come out to be positive, but finally I think the trial will show it's only speculation and not the reality. Reality will be after the DELIVER and the AMPA preserve trials are released.
So for the same, sir, Dr. Tiny, sir, what is your thought for the same?
Yeah, same, exactly same like Professor Manoria said. Here talking about HFpEF, right? See, we have data today that in HFpEF population, SGLTs reduce the rise of NT-proBNP. But again, we have seen that there is hardly any improvement in symptoms. So we are yet to get an answer, but we should understand that unlike HFpEF is not one disease, right? HFpEF is somewhere where it is an endpoint of many diseases. You can have obesity, you can have obstructive sleep apnea, you can have hypertension, you can have so many diseases where there is myohypertrophy ending up in HFpEF. So it's very unlikely that you will get one drug which is a magic cure for HFpEF. For example, there are many. TopCat trial had failed. But today we know that there is a subset of TopCat very clearly which benefits with mineralocorticoid antagonists. Okay, so similarly, but all of us working in cardiology, our hopes are pinned on to SGLT inhibitors. We believe that if some drug gives us a benefit, one single drug, there will be two. One would be an SGLT inhibitor, dapagliflozin, and the second would be probably a combination with an MRA. In fact, Dr. Milton Packard from the editorial also says that perhaps a combination of MRA and SGLT inhibitors might be the drug of tomorrow, which might try to stop the endemic or epidemic of HFpEF.
Thank you so much, sir. Another question for Dr. PC Manoria, sir. By the great results in the Dapa Ckd, does it excites you?
What are the?
Such a great result by the Dapa Ckd. Yes, sir. By the great results of the Dapa Ckd, does it excites you?
It is very, very exciting. The trial was prematurely terminated. And now we know it is a signature effect of SGLT2 inhibitors. What is very interesting, it should be used in early stage of CKD, right in stage 2, where eGFR is borderline 60 to 90. And I've already shown the declared TMI, the benefit was seen with mean eGFR of 85. So earlier you use, the better are the results. Although the benefit takes time. Later you use, the curve starts separating early, but the benefit is still there. So overwhelming benefit, very, very exciting. And that's why the trial was prematurely terminated. CREDENCE was also, so it's very, very exciting. And the benefit is across the board, diabetics, no diabetics, age, everything, all subsets benefited. All hazard ratios are to the left. All confidence interval except CVD are to the left. So benefit, 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 no harm, no harm, no harm. That is the message of excitement from the DAPA.
Thank you so much, sir.
The confidence level not touching the midline.
Yeah, rightly mentioned, sir. Sir, Dr. Tiny, what is your view for the same?
Oh, absolutely same. Nothing new to it. Absolutely ditto.
Yeah. Thank you so much, sir, for instrumenting the whole question very beautifully. So now at the end, I would like to request Dr. Harpal Singh Malhotra, sir, for the providing their closing remarks. So, Dr. Harpal, over to you.
Yeah, thank you so much, Nishant. I'm audible.
Yeah,
Yeah, so
yes.
it was a treat to listen to both the leaders in cardiology, Dr. Tiny Nair and Dr. PC Manoria. I will just reiterate few points which I liked in their presentation. The first point from Dr. Tiny Nair, he said that guideline-based medical therapy only 24% patients received it. That was a very bold message he gave. 76% patient level left. It is a lesson also for all the physicians that we have to use this. And he also mentioned about early we use, better it is, and start early. He explained the graphs very well. He said both the EGFR less than 60 or more, the CV death HHF benefits were there. Diabetic use, he said, there doesn't make any difference. Systolic blood pressure, he also mentioned, and 90. And again, SOC of Arni, every point was very well explained. And he said the all AIC levels, GFR, all diuretics. He also mentioned about left ventricle ejection fraction and anti-proBNP, and also last but not least, anti-Indian subsets. Dr. Manoria, I think he did a fabulous job again, sir. It's always treat to listen to you. Not only he said that cardiorenal, but he also mentioned about liver and other organs, and he said that prevalence, and he mentioned about the point he mentioned about declare EGFR was healthy. Dapa CKD, the results were fabulous, and he has mentioned 39% primary endpoint reduction, 44 renal composite, 31 all cause, and apart from that, I think he also mentioned very important point. There was a reduction in sympathetic activity, anti-sympathetic activity, which has to be explored. And he mentioned about DARE 19 study, which is anti-inflammatory. You have to watch for that. And renal benefit, he said, obviously it was more than cardiac, and it's a signature effect for cardio and renal. HFpEF, we have to wait, and but there's still to believe because it can be act through newer pathways, because interstitial edema and myocardial fibers not. And with this, I think there are a lot of other points. I will not take through everything. It was a very good, and it was treat to listen to both the cardiac leaders. And with this, I would like to thank both Dr. PC Manoria and Dr. Tiny Nair for such a lucid and elaborative presentation. And also thanks to you, Nishant. Thank you for all the delegates and doctors who listen,
Dr. Tiny
joined this
Nair.
evening. Thank you so much, sir. Stay